Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree, Chappell, co-editor-in-chief and host of Top Med Talk here at Anesthesiology 2025. I'm joined by my co-host, who I've been saying is just one cool guy. Saul Aronson.
Could be worse.
Saul, thanks so much for joining in the team this year, helping out.
How fun to be back.
It is fun to be back. We missed you last year for sure.
Yeah.
San Antonio's been absolutely fantastic. Like every other year, we've had wonderful conversations already, and this is just day one, and actually the end of day one. So we've been having lots of conversations with, great trialists. We've heard a lot of breaking news from some of the bigger trials that we're hearing about. We've heard from some of the ASA committees. We've heard from some of our sponsors. It really has been a wonderful day.
We packed a week's worth of information in our economic committee meeting
We
in
did.
30 minutes.
Yes,
Wow.
we did. We
Must
did.
tune in for that one. It was intensely good.
Yeah, and actually, Saul, it was a great precursor or a pre-read or pre-listen to this conversation that we're about ready to have on the workforce and the workforce of anesthesiology. And so we are so privileged to have our next guest with us. We have Dr. Dale Peterson, who's actually been one of a Top Med Talk favorite of the podcast. So, Dale, if I may, thank you so much for joining us again.
Thank you, Desiree.
Yeah, good. Well, for our listeners, why don't you tell us a little bit about yourself?
Well, my current role is Executive Vice President, Chief Operating Officer of Driscoll Children's Health System. And we cover pretty much all of South Texas, taking care of kids with our now 2 hospitals and clinics spread throughout and our 200,000 member health plan. Of course, my journey was, started off pediatric anesthesia, critical care, at Driscoll for 30 plus years.
Yeah.
Where she taught me to put an IV in a little
right. That's right. I remember you saying that, Saul.
Small world.
It is a very small world. And I think, Dale, we've had lots of great conversations with you, but my very first memory and podcast we recorded is whenever you were transitioning out of your presidency for the ASA and heard about the amazing work that you did during COVID and the entire team, but leading that. So I do recommend that you check that out because it was a really good conversation. Joining you today, we have Tom Miller. Tom, thank you so much for joining us here on the podcast. Yeah. I know you said you had talked to Monty. I think it's been a while back here on the podcast. But why don't you tell us a little bit about your role here within the ASA?
Sure. I'm the Director of Analytics and Research Services and also the Director of the Center for Anesthesia Workforce Studies, which was created back in 2017 by Dr. Jim Grant, who was president then.
Yes, of course. That's great. So. Well, it's always good. You were talking, you're like, I'm the data person. I got all the numbers. So that's a good thing. We want to hear the numbers. This is great. Well, let's just dive right in. We had a great conversation with Dr. Gall and
Gordon.
Gordon Moore this morning about the economics of anesthesiology and things like that. And we started talking and getting a little bit, you can't have a conversation about that without talking about workforce. Mm-hmm. So we're like, wait. We're going to have a conversation later today about that. So Dale, why don't you set the stage for us? The anesthesia workforce has been changing so rapidly, really over the last 10 years, but specifically in the last several years since COVID. Why don't you kind of set the stage for us and tell us where we are today?
Sure, happy to do that, Desiree. So whenever we talk about workforce, it really is that balance of supply and demand, right? So really on the supply side, as best we can tell, and Tom can dive a little bit more into the numbers, but we're in an increasingly better position, I would say. Amazingly, we've had a 40% increase in the last 10 years and the number of residents we have. It's really enough for the current job postings on GasWorks.
Uh-huh.
So, about 2,300 or somewhere around there. And so that's kind of the good news side. And then if we look at the other professionals we work with, whether it's CAAs or nurse anesthetists, they are increasing their training as well. So the pipelines are, I would say, robust. And we're getting fabulous people. Yeah. All the residents that I see, and when they come into practice, they really are well trained. And so we are getting fabulous people. So that's part of the supply side, right?
Yeah.
Tom can talk a little more about this, trying to figure out how many people are retiring.
Yes.
And then you and I talked about maybe some of the generational differences on how many hours people want to work, kind of thing.
Yeah.
But let's talk about really the biggest issue, I think, that's impacting and making us feel like it's really awful and painful.
I was just going to say, so what you had said felt very good. I was I love to hear those numbers.
Right.
Thank you all for coming.
I wish. I was like, and cut. Because I will say, as a clinician myself, sitting in the OR and listening to we don't have enough to cover the rooms today, and it's getting super, super tight sometimes. It doesn't always feel like that. So it is great news. But tell us why kind of it's been feeling like that, and where you talked about retirement, people who are retiring, and the numbers.
Well, I don't think there's this huge exodus. Initially in COVID, we thought there was, mm-hmm. and then I think we've seen, sort of a stabilization of that. But let's talk about the demand piece, because yes. I think that is really the major factor that we're experiencing. And that really is this explosion in other procedural care. We call it the NORA care, right?
Yeah,
the non-operating room anesthesia locations that we've got. Whether it's your GI suite or it's the cath lab, or, we've moved a lot of procedures to less invasive procedures, and they're going all the way over to your hospital system into, I call it the Timbuktu area.
Yeah, safari is what
Yeah. And so it creates a lot of demand, and at the same time inefficiencies.
Yeah.
And so how do we manage through that? And we'll talk a little bit of some solutions around that. But I think when we look at the number of surgeons that are out there, we're creating more anesthesiologists than surgeons, than all the surgeons.
Yeah.
But we're not keeping up if you add in all the proceduralists.
Yes.
So the cardiologist, the interventional radiologist, the whatever,
interventional, name your specialty.
Yeah, that, and I think even though you can do endoscopy, screening, colonoscopies, the old-fashioned way, I've had it done that way with Versed and fentanyl with the surgeon or the endoscopist, works perfectly well. But I think they've all learned and know the studies that if you have a professional anesthesiologist, anesthesia care team involved, they can get throughput, they can be more efficient.
The efficiency change.
And you're adding a level of safety there as well.
Yeah.
So, that's a more of a demand that we didn't have before.
Mary Dale, in addition to the non-operating room locations within the hospital, also there's speak to, if you will, the payer pull to get out of the hospital, the ambulatory surgery centers that are now doing cases that heretofore used to be done in the hospital because they won't be reimbursed if they're not done in those locations, stretching even further the geography of need. Yes?
Oh, for sure. I mean, an explosion of ASCs. And, of course, Texas, we're not a certificate of need state, so we've seen this for a long time. Right. And then you've got the financial piece of it where surgeons can get a piece of the action, so it's financially viable for them. And then one of the looming things that's coming up that actually concerns me greatly is the potential change in the CMS rules on the inpatient only kind of thing, where it's Pandora's box opening up, and where it's going to put a lot of pressure on our members to do sicker and sicker people in these outpatient centers. I think that's an area really ASA needs to look at. But to your point, because we're talking about workforce, to your point, it creates some inefficiencies out there. That when you're kind of all in one location or close to one location, you can use your resources a little bit more easily instead of having to travel all over, cities. And hard to travel in cities, right?
Yeah, it's true. Oh, go ahead.
So I'm going to hold you now to the opening banner. We're fine. We got enough people coming down the pipe in the next 3 or 4 years, as long as the goalposts stay where they are. But you just taught us they're moving. So where is that gap? How do we assess that and manage to that?
Well, how many people ask this often of Tom and me, and how many people are we short? And who knows? But if we look at the job postings, okay,
Yeah,
how many
which is
people
a
are posted
reasonable
for a
way
job?
to
Okay,
look at that.
there's about 2,300 right now, and that's been actually pretty stable for the last year or two, with some little ups and downs. That's for anesthesiologists, and there's about a little over 3,000 for nurse anesthetists that are posted. So
That's a metric.
that's a metric, that we can say is out there.
Yeah.
That at least people are willing to pay and hire, that number of people.
Okay, I have a question for you. So going back to this Nora and being outside of the normal operating room, which was, you talk about points of service and you have this set point of service, but then speaking of goalposts, those all move because they're like, oh, we need you to go to IR today, or we need you to go to MRI, and that wasn't on the schedule, but we need to put you in there. That's created a lot of stress and strife. And then the ASCs. Tom, can you give us some numbers to kind of make that real for us? What has that expansion been looking like? Is that another thing like, oh, I don't know?
Sort of. The great thing about workforce is it's interesting. The bad thing about workforce, it's pretty challenging. I think on the demand side, it is that number of going up quite a bit. I think what's challenging, and I'll put not my number geek hat on, but my health economist hat on, is that on those numbers where you see job postings, what we don't know is, are these just people that want doctors because they want to increase their market share, they want to grow, or is it really what's needed for the population?
No, that's true.
And so that's a challenge on the economic side. The other thing we do know is that markets, and even labor markets, hate being in disequilibrium. So they're constantly in flux and constantly making changes.
Yeah.
And so despite the fact that anesthesiologists has outpaced in terms of numbers all other clinicians except interventional radiology, interventional cardiology, et cetera, it still sometimes doesn't seem like enough. And so a particular market, a particular practice, a particular doctor may feel these strains of like, oh, it's going crazy, there's a huge shortage. What's really hard is we don't have a generally acceptable definition of what a shortage is.
Yeah.
Even those folks that do projections out in time, they start with an equilibrium because no one knows how to define it.
Yeah.
And so we've had more disruption. People would say, well, it disrupts surgery, it does this. But there's more disruption from the 2024 Hurricane Helene when it went after North Carolina and flooded the Baxter. Yes. That had more surgical disruptions than any shortage in surgery, right? Except for local markets where a hospital let go of complete practice and you see some disruption. So it's very challenging, very difficult, but it's fun to look at. And I also am very positive in terms of the demand. That is a real demand.
Yeah.
Whether or not it's a real need, we don't quite know yet, but it's definitely a real demand. And like you said, the people working today are very different than the people working 20 years ago.
Yeah.
And Tom, let me jump in. It reminds me of just trying to come up with a number for unemployment. Obviously, it depends on who and how you measure that, and it's constantly in flux. Who left the workforce, who's looking really, really for a job, et cetera. Integrate into that discussion the locums pool, which is just ballooned because of, if you will, that supply and demand reality of economics. And how much of that are we counting in our shortage discussions? And how are we even understanding how to count that?
The locums numbers are difficult to get, but they are in the numbers of supply.
Okay.
So anyone that's billing Medicare, anyone that's actually practicing, those are in the numbers. It's hard to tell who's locums and who isn't, and it's hard to tell how productive people are and things like that. But those are in the numbers. And you talked about a 40% growth in 10 years. It's 100% growth in 24 years. So again, demand is increasing. We still have, since 2002, I think it's been over 95% filling the positions. And the only bad years were back in the mid-1990s when we had that big dip in residency programs. that keeps following us around in 8 to 10
But we're all
years.
retiring, so that'll eventually go
It'll
away.
be fine.
So because
Some of us have.
and retirement is one of the toughest things to get a handle on, but there are two organizations that do a lot of projections, AAMC and then the Health Resources Services Administration. And both of those, if you look at their models, if they just change the assumption on how many people retire, that has the biggest impact on sort of supply supply and also shortage versus surplus. So retirement's extremely important to get a handle on. And so with compensation increasing, with people changing and getting worried about the financial future, some people are hanging on.
It's hard. It's really hard to predict. It's like 2008. Like a lot of people stuck on because they didn't want to retire when they had anticipated they were going to.
But it's a cliff too, because
it is a cliff.
You know, those people are hanging on because God knows what the stock market did today, or you know what the remuneration tolerance is for services tomorrow. It could crash quickly.
Yeah, one of the topics that I wanted to pull a thread on, because this is a conversation that I have continuously, I think anesthesiologists have done a great job kind of getting in and covering all those extra points of service, right? We do it, we get in there, we make sure everything's covered, and we somehow pull it together. But it's a lot of work, and it's really super hard, and it causes burnout. We've been dealing with those kinds of stressors. But we've talked a little bit about here on Top Med Talk about, is it right for anesthesiologists? Are they the ones that should have to be covering all of these different areas? And are there ways to share the model or look at other models that we haven't necessarily even thought about to still have it within the world of anesthesiology? Because this is sedation, this is, you know, these different areas, but then to figure out how else we can do it.
Yeah. So, you know, I saw a recent article, Barbarians at the Gate, and talking about other physicians who are getting in on this.
We all read that article.
Okay, so my response to that is, let's own it.
Yeah.
Okay, people, let's just own it. So I think the children's hospitals have done a pretty good job of that. So, yeah, I'm in a part of South Texas where I had chronic shortages forever. I mean, and when we look at around the United States, I mean, I did a talk in Massachusetts. They have twice as many doctors per capita as we have in Texas.
Yeah.
I don't think half the people are going without care. We figured it out, right? So what do I mean by that? Well, the children's hospital, I could never be there for every broken arm, every bone marrow, every whatever. And as, you know, the pediatric anesthesia resource gets tighter, you know, what are ways that our department can extend ourselves, still oversee the quality of care,
Quality and safety.
the protocols, the safety, which we're required to do, by the way, by, you know, CMS. And so how do we do that? Well, in our case, and I'm not the only one, we hired full-time, sort of retired or burned out or whatever you want to call them, pediatric intensivists who are very adept at drips and airways and all of that. And we create, I figured there were about 1,000 cases a year that could be pulled off of our pediatric anesthesiologist schedule that they could do. A big piece of that in pediatrics is MRI. Mm-hmm. And it's all about how you triage and how you set up your sedation program. So before a child is scheduled for an MRI, we have screening questions and things that we use, you know, age, you know, what health issues they may have, what kind of MRI, how long it's going to take. And so group 1 needs nothing. VR, watch a movie, they're going to be good to go, right?
Yeah.
Group 2, they're healthy kids for the most part. It's going to be less than an hour's study. We believe that our full-time other physician who specializes in just pediatric sedation can do that. And then we have group 3 that's going to require a pediatric anesthesiologist. And so we have a full day scheduled for the sedationist. And their goal is, you know, and some of those kids may not even need sedation. If so, that's fine too. It'll just be monitored care, right? And so you can pull a lot off of your schedule. even those hard LPs or things that were scheduled in your procedure room, your bare exams in kids that can be lengthy. All of those things could be pulled off your schedule. Pediatrics has done this. I haven't seen as much of that in the adult world. It requires a team. So I had to hire sedation nurses. I had to hire, physicians that specialize in this. We had to make sure we had the protocols in place.
Yeah.
We had to make sure that we're working with the other service lines so that we take over scheduling. No, you can't schedule a case before we have done the triage process. So we work with those service lines in doing it. I think we need to own it, and we need to make sure that those other service lines we're working with are as efficient as what we have in our operating room, that we have block times. We're all aware of that. People show up on time, show up with your patient prepared. All the things that we do in our OR schedule needs to happen in NORA. But I do think we could use other professionals in our practice, and it could be other people that I'm not even mentioning, that we can train and oversee that can extend us.
Yeah, I think it makes a lot of sense. We have talked about it a lot on Top Med Talk as well, and really trying to be solution focused on how do we meet these needs, because it is really tough.
But the hospitals need to pay for it. Okay, you need to engage your hospital administrators. And for me, I had it was a 60-day wait for a child getting an MRI. That is unacceptable.
Yeah, the value proposition is we got this.
Yeah,
for
and
you.
even if I don't get a dime from that professional service, the hospital is getting a technical fee for that MRI that is revenue, but most importantly, the child is getting their study too. So it works.
Well, there's a lot to be learned from, I think, the pediatric case studies that the example that you just gave to see in adults, and I really feel like we're going to be seeing more of that. I know there's a lot of discussion.
But that's right. There's also various practice patterns across the U.S. that are very different.
Yes.
So in some parts of the U.S., very few patients undergoing cataract surgery
That's a huge
will have
question
an
right now, right?
anesthesiologist there. And then in other parts of the country, it's 100%. I think they've evolved differently, and times have changed. It's not a 2-hour complicated procedure. It can get complicated, but most of the time it's not.
Yeah.
I think those are conversations that at each institutional and local level, as we have constrained resources, people need to determine what's best for them.
Yeah.
In addition of Mary Dale being a super administrator, she also reads minds. I was going to go in that same direction. Couple things the data do show is that the variance across the country is almost mind-boggling in terms of practice patterns, ratios of nurses to physicians and things like that. And in some places, when you bring it up, people get so very concerned about the high ratios of CRNAs to physicians and things like that. But on a national level, the ratio still now, even though the CRNAs are putting out more than twice as many CRNAs per year as doctors are coming out, and they're growing fast, we're still sitting at like 1.3 CRNAs to one physician nationally, maybe a little bit less depending on what numbers you look at. But for that, even at that rate of increase, for that to grow to some big number like 2 or 3 or 4, it's going to take years and years and years. So we have to do these kind of solutions now.
And there's lots of different models. Go ahead.
So I would say yes, there's geographic diversity that is
huge,
crazy. Very different in an urban center versus a rural center and remote centers and all this sort of stuff. So the point of, look, it's Tuesday. We can't run 8 rooms. We only have enough bodies to open 6. Rubber meets the road moment, right? Happens every day.
Right.
So I don't care what the national statistics are. I can't open up my second. So at that point, is that the trigger for that institution culture to say, hey, we got to start to peel off and use the ologist to do scope of service that really is aligned to their training, and maybe we need to reevaluate where that line is.
Exactly, Saul. And that's what we did in our institution. And not only that, but it's also have a conversation with the surgeons. No, you're not going to have all these standby rooms, or no, we're going to have more efficient posting, and well, okay, if you can't get here till 8 o'clock, we're posting cases ahead of you. And it's all of those other conversations that increase the efficiency of what you're doing each and every day. Because we all know we deal with that in our, and there's nothing more frustrating
So
to an
hard.
anesthesiologist to be sitting around. And, you know.
And the other corollary to that discussion of triage and most efficiently aligning scope of service to need is another expanding potential role of anesthesiologists in the determination of readiness. And how has that been incorporated into the workforce modeling that we're talking about? Because right now we're talking about we got 8 rooms on Tuesday, we need, to staff 8 rooms. But that doesn't account for the other sort of evolving roles of anesthesiologists to help enable that triage efficiency.
Yeah, and I don't know. So you're the expert on this one.
I know, it's a leading.
You really are. But I would challenge a little bit. Once again, I think anesthesiology departments need to own it, but it's not like they're the ones that necessarily have to do every piece of that. So, I mean, we have nurse practitioners that work in our department that we have trained that worked in perioperative care forever. And then they'll call if they have questions or whatever. There are some patients that need to be seen by our doctors, yes, but a lot of it can be done, or some people are hiring other physicians that they train in that arena and looking at what they need to evaluate. Yeah. We need to own it. I'd love to hear your perspective, Saul, but I don't think we necessarily have to take that many people out of the OR to own that.
Well, my perspective is this. I agree with you, violently agree with you, and we can't afford to do it any other way. The economics are just screaming the answer.
Yeah.
Okay,
so not to pivot, but to pivot just a little bit. One of the things I'm extremely interested in as well is that we have an evolving workforce, and the needs and the desire of the workforce now looks very different than the generation before them and the generation before them, and good or bad. And I think good in a lot of respects because prioritization, priorities have changed, the family models have changed, all those things. How are we in anesthesiology really adapting to the new workforce, as I would call it?
Well,
I
I
don't know
think
if
it's
new,
hard. Any adaptation is hard. It's what just kills us is the call. I mean, it's all about the call, right? And I hope that, young people that go into anesthesiology don't do it just because it's, quote, a lifestyle specialty. Go into dermatology if that's what you want.
No, that's definitely
I always apologize to my husband. I'm so sorry that I decided to be, do pediatric cardiac anesthesia and work crazy hours. I'm so sorry. I could have been a dermatologist. Our lives would have certainly been a lot simpler, but that's not what I loved, right? So, I hope people understand that, patients need us at all times, right? But I think, the compensation models that I'm seeing out there, you're paying handsomely for people being on call and doing that. And yes, you're right. There are people that say, I just want, a 7 to 3 job. There are openings for people like that. And big groups have openings for that. There are openings for people doing part-time work. Won't be a partner track. But there are openings for people.
I think we had, the ASA had put on 2 anesthesia workforce summits 2 years in a row. And I think one of the themes that came out of it very strongly was people that seem to be very successful in recruiting and doing things is being extremely flexible with, I have people that want to work 60 hours a week. I have people that want this 8 to 5. I have people that will take call, maybe a 50% premium, whatever. But the flexibility in the models to adapt, because it's not bimodal. It's not like people that want to work hard and people that don't.
Exactly.
I mean, it's very...
And everybody flexes in their own career.
Exactly.
You're getting out. You want to work a lot.
Yep.
I want to pay off all my bills, and pay off all my loans.
I mean,
and then
larger groups have more ability, I think, to do
I was
that
say,
than a smaller group does. But I know my son's in a very large group in Austin, and it's a really true market-driven model of call. All the partners have a certain number of calls that they have to take per year, but it can also go onto the marketplace where you can sell your calls, and calls are worth different value. And if there are more sellers than buyers, then the call pay goes up over a period of time. So, if you're taking
It's a great model.
if you're taking call at the level 1 trauma, that's going to be worth more than the overnight call at a community hospital where you might do a couple little cases.
It's a free market.
Free market.
Yeah.
And it works because it's a large enough group. And then you have people like my son who, first degree was in economics, and it's like I have a young family.
You're like, that's good.
I want to, pay off these bills. I want to do that. To your point,
Yeah.
he's one of the young people that actually takes all the extra calls.
Yeah. It's like,
But you got people that are closer to retirement, and they're willing to sell them.
Yeah.
And the transition to hospital employment is a big one that now, and I think we both still agree that private practice is probably more productive, and the numbers support that.
Yeah.
But as a hospital employee, I mean, they take on different roles and things like that. And so now it becomes the hospital's problem of managing these different types of people and their different desires in terms of work-life balance and things like that.
Well,
So
it's academics is employed
Classic.
forever, right? And now you're seeing, hospitals, like ours who have more, I actually have one group in one hospital that's employed, and the group in the other hospital is a coverage model where, I'm paying for another group to provide the coverage. Both can work. I'm really agnostic on that.
Yeah.
I agree with Tom. I am a big supporter of private practice, actually. But what we're seeing in various specialties is the implosion of private practice because of the economics and really the government payers.
Discussion you had this morning.
Exactly. That's why we got into this zone.
And so you end up with more and more subsidies. But whether it's private practice or employer
whatever it looks like,
you're subsidizing the anesthesia care. But on the other hand, and I had this conversation Friday morning with my fellow COOs of all the children's hospitals in Texas, and one of them said, we're having to change our payment structure. But when I look at the revenue each OR generates, it's kind of like a no-brainer. Am I going to do this, or am I going to close ORs? I'm going to do this.
Yeah.
And can I talk about something a little bit?
Please.
Not as far. So one of the things I've studied when I was at the ASA is some of the market disruptions, where you hear like, oh my gosh, a practice woke up one day and they were fired.
Yes.
Or, oh my gosh, this contract all of a sudden suddenly ended. I work out of Des Moines, and Des Moines just had this happen. And so I looked at some of these places, and it's not always the case, but in a lot of these markets where the disruption seems to be occurring, you have the case where the anesthesiologists are a private practice and the hospital employs the nurses. So the nurses are now part of the culture and the whole ambiance of being part of the hospital and all those discussions. And then this anesthesiology group comes in, and they work together in a care team model. So they're working together, but they're still separate organizations, separate incentives, separate things. And so it's much easier for a disruptor to come in and say, you keep your nurses, but, here's a better contract. It's very interesting. I don't know all the details, but it's clearly, there's too much of that, I think, where the people are separated. And so whether it's employment for all of them or they're all in a group practice.
It really impacts the culture.
Yeah.
The culture
we know for a long
group.
time that model is doomed to fail at some point.
It is, and it's so sad because it can be so great, and it's a thing of beauty when we have these really nicely working care teams together that are all on, we're all on the same team.
Right.
So it's sort of a warning out there to our listeners.
Yeah.
Don't drive without your seatbelt. Because the risks are higher that something bad will happen.
Yeah.
Oh, well, my goodness, we could talk all day. I love this conversation. It is fantastic. So thank you so much for coming back, and thanks for joining us, Tom. I know that people have lots of questions about this. Where's the best place to find out more information for them to get some of the numbers, to find this rainbow or the sunshine, the rays of sunshine about how it's not so bad?
Well, I just want to put a plug in for the Center for Anesthesia Workforce Studies. And so we have all this beautiful data, and it's refreshed.
Beautiful charts.
It's refreshed every single month.
It's on the ASA community.
Yeah.
Okay.
And plus, if there's something missing, they can email us. We will either get it for them or find the right person.
And it's all archived on our website, asahq.org, and you go to the CAWS area, CAWS, of the website, and We've got all of our enduring materials from our workforce summits, solution-driven, things that you
Collateral
can look at
materials to
that
help,
that
yeah.
that give you ideas of what might work in your own location when you're struggling to not close rooms, or what do I do? How do I talk with a hospital
Well,
administrator?
that's what I was just going to say. A lot of people have questions about how do I actually take and action the data that you guys are sharing and make sure that I can share this with my administration to make a change.
We've got even, compensation data and what's happened there on various, entities. And so it's very well done, and it's updated every single month.
Fantastic.
Great stuff.
Yeah. Thank you all
Thank
so
you
much.
very much.
Really appreciate it. And thank you for listening to Top Med Talk. You can find great conversations like this one and others, again, with Mary Dale from previous years at topmedtalk.com. We are on your favorite social media platform. We're on your favorite podcatcher. You can find us all over the place. If you find us, please give us a thumbs up, give us a star rating, make some comments. We love to hear more about what you want to listen to, so please let us know. We want to give a huge thank you to the American Society of Anesthesiologists. We couldn't do it without you. We couldn't keep Top Med Talk free and open to the world to hear these conversations. So thank you so much. Cheers, everybody.
Bye-bye.